Hi, welcome to BariNation, where we support the bariatric community with humor, humility, and honesty.
You've just tuned into a podcast that welcomes you into a community, a resource center, and a safe place that powers your journey towards personal wellness.
Our goal is you leave us today feeling hopeful, inspired, and ready to live your best bariatric life.
Hey BariNation, it's April. We recently launched our Drive to Thrive campaign, and that means that we need your help to keep the support coming. BariNation is a patient-founded and patient-led organization that has resisted the commercialization of our platform because we want to ensure that patient voice remains front and center. That's why you don't hear a lot of ads on the podcast. You're hearing more from patients themselves. But that means we need your support to keep it going. If this podcast has made a positive impact in your bariatric journey, or if you have listened and learned, please consider supporting it by making a one-time or monthly recurring donation. It's all going to support the organization that is supporting you. Join us at BariNationPodcast.com to learn more about our campaign and give. You've got this, and we've got you.
Dr. Rogers, thank you so much for joining us today on the BariNation podcast.
Excited to be here.
This is the very first time that our listeners will have this opportunity to learn from you. So will you please take a few moments and introduce yourself?
Sure. I'm Ann Rogers. I'm a medical doctor. I'm a bariatric surgeon. I happen to be currently the president of the American Society for Metabolic and Bariatric Surgery. So it's all I do. It's pretty much 100% of what I do is bariatric surgery.
What drew you to bariatric care and medicine?
In a past life, believe it or not, I was a breast surgeon. And then I went back to school to do a fellowship in bariatric surgery. It's a very similar population. It's a highly female population, not 100%, but highly female. Long-term follow-up, which is great. You really get to know your patients. They venerate their surgeons. It's a great patient population. It's just that the surgery itself and the science to me is a little more interesting.
Wonderful.
Who knew?
Yeah.
Right. Can you tell us a little bit about what the mission of the ASMBS is?
The ASMBS actually has a formal mission statement, and they say that it's to enhance the well-being of individuals affected by obesity and obesity-associated illnesses through progression of or support of metabolic and bariatric surgical techniques and other interventions. That's the formal mission statement.
And really, we've been a part of the ASMBS now for a full year on the corporate council, but we've had the privilege of going for the past 2 years and presenting. And even in the few short years that we've really been involved with it, we have seen this shift or this emphasis on also starting to include the patient voice. Are there aspects or elements of the ASMBS that are patient facing or patient forward?
We have a whole part of our website that's dedicated for patients. So patients, for whatever reason, if they find their way onto our website, we'll find a patient-facing section that I think is really, really informative, and it has patient testimonials and FAQs and you name it. It's got a lot of information, and we have patients involved on our corporate council, and we actually have a patient education committee that's manned by doctors and integrated health people, to provide education in a variety of settings for patients.
And we've actually linked this patient forward website in our show notes. So if you open the description of this show, there's a link, ASMBS patient page link there. And we absolutely recommend you check it out. The resources there are phenomenal, especially if you are in the pre-op stages and you're curious about the different surgery types that are out there. The page does a wonderful job of really breaking that down, and also talks about some of the things to be aware of before surgery and after surgery.
Yeah, it also talks about the medical conditions that can be associated with weight. And I don't necessarily want to focus only on weight. And I know a lot of people do this because they want to lose weight, but it's also the surgeries are very good at helping improve quality of life and improve a number of diseases and to prevent a number of obesity-related diseases.
Jason and I know about that well. Both of us have experienced a reversal of some metabolic diseases and conditions because we have undergone bariatric surgery.
That's fantastic.
We were actually having a conversation with, I believe it was Dr. Chen and possibly Dr. Cribbins. And they said something really powerful that while the outward facing outcome of surgery is a change in your weight, right? In your size and your shape. What it's really doing is addressing all of those underlying things that are happening in a person's life that aren't necessarily visible, right? Like Jason, your high blood pressure. You've talked about this many times on the podcast. You wouldn't know outwardly that you were struggling with that, but bariatric surgery helped you reduce your high blood pressure.
A little bit, yeah. It runs in my family on both sides, so it will never go completely away, but I am down on the amount of medications, and the types of medications that I'm taking have been adjusted dramatically since
That's pretty typical. I would say about 60% of people who have weight loss surgery will see some improvement, if not cure. But yeah, skinny people can have high blood pressure too. But other things are in the 90s, things like fatty liver and obstructive sleep apnea and whatnot.
Yeah, those things have definitely improved in me. I did tell them that I will have to wrestle my CPAP away from me because I've grown so accustomed to it and the sleep is so good. I don't even want to know what it's like. A
lot of people feel that way. It's amazing. You may have to dial it down a little.
Maybe a little.
Mm-hmm. I feel like you're describing myself, Dr. Rogers. I had fatty liver disease, obstructive sleep apnea. My A1C was in the pre-diabetic level. And when I had my surgery, my surgeon said, you have to come to your procedure with your CPAP machine. We won't perform this unless you have it. And I never wore it another day in my life.
That's amazing. Yeah, it's one of the first things to go. It's really, really good for that because it's gotten to be exceedingly common amongst people in developed nations to have to use that CPAP. And it's a pain to travel with it and to use it. It's hard for some people to get used to.
Mm-hmm. It was very hard I struggled with it for a decade. I fought it. And then, it really was miraculous. I couldn't believe it that it was literally the day I had surgery was the last day that I wore that machine.
I think it's interesting that a lot of people just think it is about sleep quality. They don't even realize it's a major strain on the heart to not be treating your sleep apnea. It's another one of those silent killers like diabetes.
Right. So I guess this kind of leads to a question that I didn't even think that we would ask. Why do you think then that people resist having bariatric surgery? It helps address or cure so many health issues, but yet people only look at it as a surgery to help you lose weight. Where do you think that disconnect is?
I have a number of thoughts on this, but a lot of it gets back to the theme of my year, which is the stigma of obesity. And I think, I was talking to a guy a few months ago, and he happens to be a dating coach. And he was saying that, a lot of people think that it just won't work for them. But he says, look at you. You're a bariatric surgeon, and every patient that you take care of has been dieting since they were 5. And they don't believe they will ever be able to lose weight. But they will. It's the same sort of thing. It's just entirely different from conventional diet and exercise. And I think partly people are unaware of that. Partly, I think doctors are not up to date on how safe it is. They think it's rash. They think it's the easy way out, and I always say, well, if you're in a burning building, are you going to take some Byzantine route or are you going to go the fastest way right out the door? Right? Why not take the easy way out? And it, by the way, it's not easy. You know that already. It's by far not an easy thing. It takes a lot of courage to enroll in and to get through something. It's a lot of work. You know that. Mm-hmm. And then it's an operation and you recover and blah, blah, blah. But I think a lot of people think that it's a way around just getting your face out of the trough. There's so much stigma about obesity that there's an equivalent amount of stigma about obesity surgery, I think is the bottom line.
It's one of the reasons we started BariNation, or way back in the day when we were called East to West WLS, is we were so happy and thrilled with the results that we were seeing from our bariatric procedure. We wanted other people to know about it because it took us probably 2 decades combined, if not longer, to make the decision to have surgery because we thought all of those things. And in our hearts, we believe and still do that the more people who can hear and see patients living successfully after surgery, the more people we will inspire to book that consultation and just learn more about the life that can exist for you on the other side of surgery.
That's very interesting. So you actually have listeners who have not yet undergone surgery.
Oh, yes.
That's great. That's great. It's great to educate as many people as possible.
Yes, absolutely. You said earlier, the theme of this year's ASMBS conference is lifting shame and stigma. How did you arrive at that theme?
This has been the whole focus of my year. So my year goes from June to June. And then my annual meeting is going to be in June in Washington, D.C. And I decided that my theme was going to be ending the stigma of obesity. And it's something I've cared about for a very long time. I was a member of the weight bias committee of the Obesity Action Committee for some years until my OR day changed. I couldn't attend anymore, but it's something near and dear to my heart. And, one of our past presidents some years ago, Stacey Bretthauer, was giving his speech at his, annual meeting. And he said that obesity is probably the most poorly understood medical problem. And I think that is really true. And I think if we can attack the stigma angle of it, it'll make it easier for people to access the treatments that exist because it is just a set of medical problems for which we have medical treatments. There shouldn't be any stigma whatsoever. And we know that there are other health issues such as mental health and alcohol abuse disorders and things like that that have had a lot of stigma attached to them. And then once we get beyond that and people start getting treated, it becomes accepted. So it is my greatest hope that that's going to be the same for obesity treatments.
Yeah, we couldn't agree more. You spoke on this a little bit. How do you see shame and stigma preventing people from accessing the obesity care?
They don't even want to go into a doctor's office. They're sure that they are going to be put down. And we know that happens. There's all sorts of literature that says that health professionals, even people who work in obesity facing fields, tend to put patients down, whether it's openly, overtly, or just they don't even realize it's happening necessarily, but they can say some pretty hurtful and harmful things. And a lot of patients just don't even want to go there, and it's also hard for them to maybe get to an office, or maybe the office doesn't have chairs and doorways that fit them. It's just the whole system is not set up appropriately for people of size to access in a lot of places.
We were actually talking about this this week in the BariNation membership community. Some of our most poignant conversations happen when members join one of our support groups or classes or meetups, and they talk about an experience they just had, even at a bariatric follow-up appointment.
Yep.
And it breaks our heart because they're excited to talk about, the things that they're learning and what they've done, and they would like a benchmark of progress. But then when their bariatric surgeon responds with something that is a little bit judgmental of maybe where they haven't been, it just opens up this whole spiral of shame that is hard to break free from.
Oh my gosh, yes. In fact, I was surprised to see that, I won't name any names, but the surgeon on my 600-pound life is a real guy. I was kind of amazed to see that. And a girl who was previously my bariatric nurse practitioner sent me a refrigerator magnet that's that guy, and it says, "Why you eat so much?" Right? So it's like, what the heck? This guy's in the field. This is what he does for a living, right? And this is how he talks to people. So it kind of gives our field a bad name, but I don't think he's the only one, unfortunately.
It's a struggle, right? Because sometimes we need that tough love, but other times we need care and compassion and understanding. And as a patient, right, if you have a difficult time advocating for yourself because you felt like for years that this disease was your fault, instead of, right, a disease, it can be challenging to say, that's not actually helpful, or, here's
Right.
how I like to be cared for.
I think there's probably a way to give both at the same time. Tough love, but understanding what people are struggling with. A lot of times patients will ask me, well, have you had the surgery? Because they sense that I get it. Oddly, I haven't, but I definitely struggle with weight, right? We all get it. You can't go cold turkey without food, right? You can't stop eating. So it's very difficult to not have that constant chatter in your head driving you to the refrigerator. And I think most people have experienced that and should be able to talk about it.
Yes.
Well, and I feel like you kind of hit the nail on the head there. I mean, it's about threading the line of being compassion, but also letting people know, kind of where the missteps are and where the things that they could do better on and those types of things. And they can both be done.
Yeah.
We've been fortunate enough to kind of see all sides of it because of the people that we've been able to interview and stories that we've heard from people, and our own patient lived experience has kind of been equal across all sides. So,
yep.
What are some things, Dr. Rogers, that you would like to see or you would encourage practitioners to do or say when they're meeting with their patients to help lift that shame and stigma that either the patient could be feeling or the own bias that's maybe being presented, right, by the surgeon?
I have a project right now that one of our medical students is working on. It's a very simple project where it's supposed to go out to our family doctors. And it's 3 questions. A patient comes to you for a checkup and they have a BMI over 50. What do you say? And one of the answers is nothing. That's not why they came to my office. Okay. The next question is, a patient comes to you for a checkup and they have an inguinal hernia. What do you say? Send them to the surgeon, right? A patient comes to your office for a checkup and they have symptomatic gallstones. You go to the surgeon, right? Okay. So we have to start with the fact that it's a medical condition and that we have treatments for it. It's not something that requires shame or blame or anything of the sort. We don't even have to go there, and they don't either. It's so important.
That is so important. If my primary care physicians, or any of them in the 43 years that I've been on this planet, would have approached it that way, to say, just like every other disease that
Correct.
humans can suffer through, for somebody to say, you're battling a disease, this isn't a you problem, you aren't doing anything wrong, your body processes energy differently.
Correct.
And there are treatments out there that can help with that. Oh, because that has nothing to do with my weight or my size. That has everything to do with what my body is doing or is not doing correctly.
Correct. And I just think that there is a lot of ignorance, unfortunately. There's a lot that, we went to medical school a long time ago and maybe we haven't been able to keep up on everything. I don't know. But people have to enter this era. I mean, the AMA decided this was a disease over 10 years ago. And whether you believe it or not, it just is. And most insurances cover at least the surgical treatment of obesity, severe obesity.
Yes. That is the other interesting thing, right? Bariatric surgery is one of the most accessible treatments for the disease of obesity. It is covered by so many insurance carriers and plans. Yet, and please correct me if I'm wrong, only 1% of the people who qualify actually undergo surgery.
Yep.
And I know this ties back into the shame and stigma. And having these conversations, we know, will help lift some of that for patients. Are there other things, though, that you wish the greater society, patients, or surgeons were doing to ensure that more people access surgical treatment?
It all does get back to stigma, unfortunately. But for instance, there are all sorts of really strange, difficult requirements that most insurances make you jump through in order to qualify. And that, for a lot of insurances, is somewhere between 3 months and a year of preoperative classes and A lot of insurances will require that you have meetings with dietitians. Oh, but they won't pay for it, right? So it's an unfunded mandate. It's like, what? I often say, if you had a hernia and they made you go through 6 months of classes to learn not to strain, how many people would have hernia surgery? Nobody would. It just doesn't make sense, right? But so they put all sorts of roadblocks. And I believe it's in hopes that a lot of people will fall out, and a lot of people do. Over 50% of people who enter a surgical weight loss program do drop out for one reason or another. And some of it has to do with high costs. Some of it has to do with the fact that many insurers, they'll pay for you to have a first-time operation, and then it's one and done, right? So don't you try ever coming back, right? So can you imagine if you had treatment for a cancer and it recurred? They wouldn't say, you turkey, how dare you let it come back? They'd feel bad for you, and they would pay for you to have further treatment for your cancer, right? It should be the same thing for obesity. It's not one and done. It's a lifelong, it's a chronic disease that wants to recur. And so we should be prepared for the treatments to go on if necessary. Like anything else.
Can't be like, well, you had chemo in 2012, so sorry.
You did that already.
We can't do that again.
Yeah. You, how dare you, right?
you had one hip replaced. We're not going to do the other one. We replaced one hip already. The other one's just going to have to ride out.
Been there, done that, right? It's crazy. When you put it like that, it just makes no sense, and I always come back to, I spend, unfortunately, a lot of time on Capitol Hill, and at my annual meeting in DC, we're going to do some visits in Capitol Hill. And so you never meet with your lawmaker, you meet with their staffers, and their staffers are these young 23 to 25-year-olds, healthy, generally speaking, beautiful, blah, blah, blah. And we were talking to this one girl, and she says, well, can you think of any other disease where patients bring it on themselves and insurance still pays for it? Why, yes, I can. Smoking and lung cancer, eating at McDonald's and having heart disease. I can think of the fact that the state of Pennsylvania does not require that you drive your motorcycle with a helmet on. So let's say you get in a crash with a head injury. Oh, you were not wearing your helmet? Oh, sorry, we're going to leave you here to die. No! These people all get treated. Doesn't matter. And by the way, obesity isn't a situation where you're just bringing it on yourself. Like, nobody wants to have obesity. Nobody chooses it. Oh, I think I'll just overeat and have obesity. No, it's something that happens because of the difficulties of genetics and biology and a number of other things. You got me started. Big mistake.
No, I think this is not a mistake. This is exactly why we wanted to have this conversation.
Oh, good. Thank God.
And I guess what I'm feeling a lot of hope on the inside, and I know Jason and I are just busting at the seams because this is what we do each and every day. But what became so apparently clear when you were talking, Dr. Rogers, was the cruelty of obesity treatment. Yep. I'm just going to say in America.
It is. It's terrible.
It's cruel.
It's not even just in the U.S. It's pretty bad all over, wherever they have it.
And no wonder so many people drop out.
Avoid it.
Yeah. Or drop out of the protocol because you already know the cruelty that lies ahead. You already, even if you don't consciously understand it, you unconsciously know. Yep. I have a year of jumping through hoops. I have a year of dealing with the reality of this disease. I still internally deeply believe that I'm causing this.
It's my fault, right? And if people find out I'm doing it, they may trash talk me. Who knows? And if there's a 50% dropout rate, that really means that only 2% of people who struggle with weight are actually even thinking about entering a program. It's a real problem. As you know.
As we know. Well, and Jason is just, or you just celebrated your 1 year surgical anniversary from your revision procedure. So you've gone through this twice.
Yes, ma'am. December 12th was my 1 year from revision to SADI from the sleeve. Yes.
Oh, that's amazing.
Thank you. Yeah,
Good job.
Thank you. We talk about the shame and the stigma, and I shamed and stigmatized myself for about
Of course
9
you
months.
did. Yep.
Nine months telling myself I didn't deserve to have a
That
second
you had
chance.
surgery and you failed it. I've heard
Uh-huh.
that from patients who've had one procedure and then needed a conversion or a revision or whatnot. And it's like, oh, I failed at every diet, and now I've even failed at weight loss surgery. No.
Yeah, I failed myself. I failed the community. I failed April. I failed Natalie.
It's so interesting because you might try several different blood pressure medications before you find one that works. And you don't think of yourself as a failure if it doesn't work the first time. You think, okay, time for the next thing. It's just,
right.
It's not fair.
Well, and I would tell 100 other people the exact same thing, but I would not tell myself that, no matter how hard I tried. And and Dr. Cribbins, when it came time, we were talking about it, and he was like, "Would you tell anybody else in the community what you're telling yourself?" And I was like, "Absolutely not."
Of course not.
He's like, "So why are we talking about it?" And I was like,
"It's so interesting."
I had no response.
These conversations help lift that, because the more people hear this back and forth banter, the more people hear the answer or a positive answer to the thing that they've been thinking up here, the more likely they are to get curious and start treating their disease as a disease and seek out treatment.
Well, I can tell you one thing along those lines, which kind of segues into a whole nother topic, which is that a friend got me some semaglutide, the pill version, which is called Ribelsis. So the higher dose is injectable. It's Ozempic or Wegovy. And I had these Ribelsis tabs, and this person, who shall remain nameless, had taken it and lost a significant amount of weight and said, "Hey, try it," because this person is from Canada. So I had like 6 tabs, and I thought, what the heck? So I took it for 6 days, and it was kind of a pain because you're supposed to take it on an empty stomach and then not have anything for half an hour. So I couldn't have my morning caffeine, which was a bit of a problem. But the amazing thing is how it silenced the chatter in my brain telling me to go think about food. I could go a whole day and be able to think about other things. This is amazing. And I don't have severe obesity. I'm just Joe Blow, right? But I'm dealing with that, right? And so everybody potentially is. So I think those medications, when they work, can be very, very effective at helping people realize it's a medical problem that is responsive to medications. So I think that's a good thing, because even if these medications don't work for an individual, they may think, well, okay, I've got this problem and one treatment didn't work. Maybe I should consider surgery. So I don't fear them at all. I think they're a really great thing to have in our toolkit.
That silencing of the food noise is something that we experienced initially after our bariatric procedures.
Correct.
But then it came back.
It can come back. It can come back, and it can be with a vengeance. But then there's other things we can do to turn it around. One of which is conversional surgery. One of which is adding medications to people who've already had surgery. There's a number of things that can be done.
Yes.
Because obesity does want to come back.
So you said this earlier, and thank you for saying it again. Obesity does want to come back. Why do you say that? Can you explain that mechanism?
It's just a chronic recurring disease that's driven by genetics. I don't know if it's because, we're supposed to be dreading another ice age and, we're supposed to have extra fat on our bodies to live through. I don't know why. I mean, genetics, we haven't begun to catch up with our own genetics. It's only in the 1970s that people started living into their 70s in this country, right? So now we're surrounded by people in their 70s, 80s, 90s, and we think it's pretty recent that has been the case. And even I, at my advanced age, have by far outlived my usefulness genetically. Not that I'm ready to die yet, but yeah, it's just complex biology. We don't understand it all, but I know that it's very willing to try to come back.
It just clicked in my brain, and this is going to sound a little odd for people who have been listening to this podcast or members of our community. I am the type of person that always wants to know the why. My brain is always saying, right, but why, but why, but why?
I know, me too.
Okay, right?
But we don't. Alas.
But we don't. And I guess what just clicked is it doesn't matter why you are experiencing or you're noticing the recurrence of some of your obesity symptoms.
Yep.
The reason is it's a disease.
Yeah, correct.
And we can give ourselves permission to stop there.
Yeah, exactly. Stop asking why, because you're looking for a why that's a blame thing. That's something you did wrong. It's pointless. You're innocent.
That just gave me chills.
Good. It should.
How am I this many years? How am I 5.5 years into my bariatric journey? And I'm just now understanding this.
I think that hopefully we all continue to learn, right? There's a lot I don't know, and I'm not a finished product. I guess I'll be a finished product when I finally cork off, but you got to stay open to it and read the papers and there's a lot of research going on trying to get to the bottom of, why obesity happens and how these treatments work. Yeah, we don't claim to understand it all. And what they knew back when you had your surgery was probably cutting edge, but there's been more stuff coming since then.
Well, and really what you just described, Dr. Rogers, is our support theme in BariNation for 2025, which is relentless curiosity.
Good. Absolutely.
We're encouraging our members. We're encouraging you, our listeners, and the people that enjoy this podcast to lean into relentless curiosity and to never give up on asking that why question, to continue to pursue these answers. But what also comes with curiosity is especially for me, which I'm going to have to embrace this year, is it's good enough to stop at because you're fighting a disease. The why is
exactly. It doesn't have to be a failing on your part.
No. And it's not a failure on my part. It is the disease progressing.
Yep. Or trying to.
Yeah. Oh, it's not trying. It is.
Well, there's a little graph that I draw for patients sometimes. Sometimes they'll come to my clinic and be upset about some weight regain. So I will draw a graph of time versus weight. Maybe it'll show up here, because what's pretty typical in developed nations is that with time, people tend to gain weight. I don't know if you can see it. See that line going up? People tend to gain weight over time. That's normal. And an operation will send you to a good weight really fast. And then everybody wants to stay at that good weight. In reality, what happens is people struggle and gain and reequilibrate and do something like this. Okay. Now, if you totally decided to go back to any old habits that you had, you would parallel that curve and you might find that eventually you regained all your weight, but you're still better off than if you had done nothing at all. Right? So I tell patients, all is not lost, even if you regain every pound, because you're better off than if you had done nothing. And by the way, it's not too difficult to get down again. Usually it takes like journaling again and, maybe meal replacements with protein shakes once a day, a variety of things. And most people will lose 5 pounds within 2 weeks and realize, okay, all is not lost. I can get myself back on track.
Yes.
Not that it's easy, but.
Yes, we have our entire supports in our BariNation membership community that are geared exactly towards this.
Yeah. We
have support groups that are led by licensed mental health professionals that are experts in helping people with weight recurrence.
Yep.
And really it starts with the mindset. It's what we're telling ourselves. It's what we believe. And we help people identify how those thoughts are maybe getting in their own way. And then we provide them the space to practice doing things differently.
Not just that, and all these mental health professionals will know that a lot of it has to do with behavioral stuff, which is all the people that surround you, right? And some of them are hurt by the fact that you've lost weight, or some of them like you because you're the heavy person. There's a variety of strange, interactional things that surround weight, so you have to not just get your own head screwed on straight. You have to know who's good for you and who is not, basically.
Well, it's one of the things we like to tell people too, when you were talking about getting, not kind of getting back to basics and starting, it's important that we're telling people that you're not starting over.
Right.
You're starting where you are because you have more tools in your toolbox now than
Correct.
you did before on any other diet when you would have just, now I failed the diet. Now we're going to start again on Monday. Any day is a good day to start, and you're meeting yourself where you are.
Yep.
You're not starting over from scratch.
No. And all these resolutions, new year, new me, blah! Start anytime.
Yeah.
Anytime, whenever you feel like you can.
Oh yeah, the countdown to the gym flood is on because I have I've been going about six months now solid, and all of the people in the gym that are core that go every day, we're just counting down because we know it's about to get busy.
Oh my gosh, that's a good point. Mm-hmm. Yeesh.
Mm-hmm. I'm gonna get a shirt made that says "New Year, same me."
It's so true. We talk about this all the time. There is no reason that we need to wait to start to do things differently or to try things differently. And as we talk often about, it's not that we are learning absolutely brand new things before and after surgery.
Right.
We're learning how to do what we already know how to do, just a little bit differently.
Well, I've listened to your podcast before, and one of the things that you've spoken about is just mindfulness. And it is very, very easy to go through life mindlessly in for so many reasons. This is part of one of the tenets of Buddhism, right? Is just to calm down and take a breath and think about the fact that you're okay. Right now, we're safe. Right now, there's no rhinoceros chasing us that I think. But it's hard to be mindful. It's so easy to just turn your brain off and go through life and wake up and realize, hey, that bad thing happened. Maybe if I'd been a little more aware, things would have been okay.
Mm-hmm. Well, before surgery, we had food to help us with that mindlessness. That was an easy pathway for us. And after surgery, we have to, as Laura Grabo teaches, right? We have to catch that thinking. We have to check it and we have to change it. But the gift of surgery is it gives us the space between what we used to do and what we want to do. We all of a sudden have this capacity to really live life differently. And that's what this is all about, getting the space and grace from the disease so that we can engage with life in different ways.
I think that's true. And you make me realize that a lot of people believe that these operations work simply because they can't eat as much. And I think that's just, they started coming up with these operations in the 50s, and maybe that was the plan, just to limit, it's like jaw wiring, just limit how much food people can take in. But most of these operations work because of hormonal effects that just so happen to be related to these reconstructions, so people should get away from thinking about, restriction and malabsorption. No, it's mostly hormonal effects. And that's why these medications kind of work in a similar way because they're hormonal agonists, right? Mm-hmm. Yeah, but I wish we could go back in time and come up with new ways to make these operations work that didn't require that much restriction, because in a way, I think people are counting on it to take care of the problem. And they're using, these operations kind of like, an airbag deploying, they're driving at 90 miles an hour and the airbag deploys, right? And suddenly they realize they better slow down. No, you got to drive slowly within the lanes and not crash into a bulkhead and not have the thing deploy, right? Yeah. So this whole thing about, it'll make me have dumping or it'll make me vomit. No, I wish that had never happened in the first place, because that's really not what these operations are based on.
Well, and especially if you're somebody like me who didn't have I have zero food aversion, so I can do whatever. I have nothing. There's no dumping. There's no any of that foolishness. So if I was counting on that to help me, I'm out of luck.
Exactly. So even with bypass patients, maybe 5 to 10% of patients have actual dumping, right? So we want to scare everybody about dumping so they won't even try cake and ice cream because the vast majority of people will be able to, right? And so then there's got to be something else that leads you to think about, am I actually hungry? Or what is my body asking for right now? Probably not that cake. And it never tastes as good as it looks. Donuts, they're never as good. You regret it afterwards, right? What does your body actually really want and need? I think most Americans don't even know what hunger is because they fear it and dread it so much that they eat constantly so that they don't feel the pain of hunger, right? Mm-hmm. They don't even know what it is. They don't recognize it. They don't allow themselves to have it, right? They know what fullness is. Fullness is like you got to unzip your pants and sit back from the table because you're in so much agony, right? It's like there are other ways to experience this.
Yes. And I know for me as a patient, I never experienced fullness before surgery, or there was maybe a few times where it was that, right? This uncomfortable feeling.
Yes, because a lot of women tend to graze. Guys will eat big portion sizes. Women will be snacking and grazing all day long, right? Yeah. So they're constantly having something in there, but maybe not filling them up.
Yeah. Well, and my hunger never dissipated. My hunger was constant. And after surgery, right, I was prescribed a GLP-1 medication, and it absolutely helps eliminate that food noise.
Yep.
I mean, I've lost access to it several times now, but it's amazing and it's frustrating at the same time because starting in 2025, I will not have access to it anymore. So my options are extremely limited.
It's deeply disturbing, and they're very expensive right now because they're not generic. And I don't think we're going to get our first generics until like 2027. So it's going to take a while before a lot of people can afford them.
We've read in the news the Biden administration wants to add GLP-1 medications to Medicare and possibly Medicaid. I mean, and I think a lot of people are holding out hope that insurance companies or the government will make these medications available. Do you see that actually being the case in the near future?
Alas, no. We have been trying to pass the Treat and Reduce Obesity Act in Congress for the last, 13 years or so. So those medications have been specifically disallowed by Medicare, probably because of the valvular heart disease that was seen with fen-phen. But we've had a number of things since then that are FDA approved that do not cause those problems, and Medicare continues not to pay for them. And they're just simply not going to pay for anything at this time. Even these generic things, right? Because of the sheer cost. I think 20% of Americans are using these medications, and they're extremely expensive. So there's just simply no way the government is going to pay for that. Alas.
Wow. So really the best still form of treatment that people can access will remain bariatric surgery.
Yes. And thankfully, most people have at least limited coverage for it. Not everybody, but most people do. Most conventional insurers do pay for it.
Yes. Wow. Okay. Well, we have just a few more minutes left. Jason, do you want to, so we have 3 questions left. What can patients do to help, or what can patients do to access care? What can practitioners do to help more people access care? And then your bold predictions for 2025.
Yeah. I think, most doctors, primary care providers are like a mouse on a wheel. They're just running to catch up. They're paid to see patients every 6 minutes. And, they may see 30 to 50 people a day and then go home and do their charting later. So it's hard for them, I believe, to keep up on, modern medical stuff in something that may not even be their field. So hopefully while they're driving, they're listening to this podcast so they can get a sense that this is a very safe set of procedures. It's the most common set of procedures done in academic medical centers. It's safer than hernia and gallbladder surgery. So it's not like the old days where it was considered rash and dangerous and, you're a high leak rate. Now that we do everything well, most things through minimally invasive techniques, laparoscopic or robotic. These have gotten to be very safe procedures. Some of them can be done on an outpatient basis, so if doctors would just realize that, I think they'd be more likely to recommend it to patients, right? And patients need to know the same thing. It's not something to fear and dread. Yeah, it's a big commitment. It's a lot of work, but there are other things that we deem to be worthwhile that we put the work in for. And this is you. This is your health. I tell women, there's exactly 2 things that women do for themselves. They get their hair trimmed every 6 weeks and bariatric surgery. It's like, nobody does this for themselves. They need to. It's important.
Yeah.
So my predictions for 2025 are that it's probably not going to be too different from 2024. I think most insurances will still cover it. I think it will still be difficult to get GLP-1 agonists for one reason or another, but I know they're working on more. So more and more are going to come available. So, it's getting a lot of play, and it's making people realize that treatments are out there. So I only see that as a good thing.
Awesome. Wow. Okay. We like to give our guests kind of the final word at the end of our show. So when you kind of reflect on everything that we've talked about today, which is, it was a amazing conversation. What's the one thing that you were hoping patients, and then the one thing that you're hoping practitioners take away from this conversation?
What I think patients should take away is I put on a pair of socks this morning, and I don't even know where I got them. It was a gift from a friend. It's got a bad word in it, which I won't say, but it basically says, you know what? You're amazing. Love yourself. And I think patients need to know that, right? You are not a bad person. This is not a failing on your part. You're worthy. You're here for a reason, and you're allowed to take care of yourself. And hopefully practitioners will hear that as well and realize nobody wants to be sick. Nobody wants to have a problem. Nobody wants to be heavy, blah, blah, blah. So just take pity on people and be nice to them and offer them some treatment.
Wonderful. Dr. Rogers, thank you so much for joining us today. This conversation was amazing.
Thank you for having me. It's been a pleasure.
That wraps up another empowering episode of the BariNation podcast. If you enjoyed today's episode, keep the conversation going by joining the BariNation membership community, where you can attend live support events, access on-demand resources, and find a caring community.
Join us at barination.mn.co. If you found this podcast valuable, help us produce it by becoming a $5 monthly supporter at barinationpodcast.com.
And just remember, at the end of the day, you've got this, we've got you, and we'll see you next time. Bye, everybody.